Hello, everybody. And for this lecture, we're going to be talking about personality disorders. There are a lot of personality disorders. This is definitely one of those lectures that you're going to want to go through the material, through the slides, listen to the lecture, and then probably go back to your book and try to find a way for you to identify the differences between the different personality disorders, because we're going to be providing you so many different facts and figures that it's oftentimes easy to confuse them and confuse the different clusters in which they're categorized under. So just to let you know before we get started there that there's going to be a lot of these. Okay. As always, we start off with some basic characteristics of the overall umbrella of the disorder. We've done the same thing for anxiety, same thing for depression. So here we're talking about some overall characteristics for personality disorders. Chronic interpersonal difficulties, problems with identity or sense of self. Okay. The DSM criteria include behaviors such as pervasive and inflexible, stable and of long duration, clinically significant distress or impairment in functioning, and then manifested in at least two areas. So, and those areas could be cognition, affectivity, interpersonal functioning, or impulse control. And when we speak of affectivity or affect, what we're referring to here is that the affect, the emotion matches the situation. So if you've heard of somebody who just lost one of their loved ones and you console with that individual, your emotions should match the situation itself, and you feel sad, you feel empathetic for that person. If your affect does not match the situation, then we're looking at why is there this disconnect, and is it possibly a personality disorder? These disorders are put into categories. You have cluster A, B, and C. A includes paranoid, schizoid, and schizotypal. B includes histrionic, narcissistic, antisocial, and borderline. And C includes avoidant, dependent, and obsessive compulsive. Okay. So, as I mentioned to you before, there are a lot of personality disorders. We're going to be going over each one of these individually. Okay. Again, overall, 10 to 20% of people meet the criteria for at least one personality disorder. If we break that down by cluster, cluster C is around 7%, cluster A 4%, cluster B 3.5 to 4%. The reason why I have it listed as cluster CAB is for that prevalence rate from highest to lowest. And then you could add 10 to 20% to each cluster just due to comorbidity. Again, that's meaning that there are individuals with a personality disorder, but they share also another personality disorder. Okay, so it's comorbid. There's more than one disorder that these individuals are showing. Okay, some research and diagnostics here. They are personality disorders can be difficult to diagnose. The criteria is not sharply defined in some respects. The categories are not mutually exclusive, which means that they share characteristics. And remember that they are all on a continuum. So what we're referring to here is that with a personality disorder, it can be a lower grade type of mental disorder. Okay. And so we have to be very, very careful when we're categorizing or labeling people with any kind of a disorder, right? So the DSM-5 is looking at, okay, this person has this and this and this trait. right? But on a continuum, is that enough to then label this individual with an actual disorder? Because that label will not leave them, right? They will be labeled for the rest of their life. So we have to be very, very careful, because we are dealing with disorders that are not sometimes as visible as some of the other ones that we've talked about earlier. And so we need to make sure that they match the criteria very specifically to the DSM-5 before that label is provided. Okay. The 5-factor model of personality, what this refers to is that if you look at these personality traits or characteristics, you have neuroticism, extroversion, openness to experience, conscientiousness, agreeableness. One, two, three, four, five. Conscientiousness is on there twice. Okay, sorry about that. So, but if you look at those first 5, okay, and you cross-reference these personality traits with the personality disorders, you'll find out that neuroticism oftentimes is a character trait in maybe 4 or 5 of the personality disorders. Extroversion, 4 or 5 of the personality disorders. And there's a very nice table in your book that shows you how those are, what that crossover is. Okay. Now, here's a little bit about what I was just referring to, in that personality disorders may represent extreme levels of normal personality traits. Okay, so this is why it's so difficult. We want to make sure that before we label that individual, this normal personality trait, right, is at an extreme level, and at an extreme enough, let's say, level for us to then place that label. And there's some examples here, like negative affectivity, neuroticism, right? Detachment, extreme introversion, antagonism, extremely low agreeableness, disinhibition, extremely low conscientiousness. Okay. On a research perspective, there's limited research on causal factors. The disorders are relatively new, 1980, doing a lot of studies on them. Less amenability to thorough study, okay, because these individuals are probably not going to be, let's say you're doing studies on individuals suffering from schizophrenia. A lot of these individuals might be hospitalized or under the care of a doctor or something. It's harder when you're dealing with the personality disorders, because these people are out and around and not necessarily under the care of a doctor or institutionalized. So finding the individuals and having them do some kind of a case study or a longitudinal study is a little bit harder. And retrospective approaches, many times, are all we have. What that means is that we see the end result of this individual, and then we try to identify, how did it come about? How did they get to this point? Looking backwards, how did they get to this person? And this might be in the case of like an antisocial personality disorder, where now the individual is in prison. They've ran into multiple issues with the law and that kind of thing, and then now we're looking back saying, how did this precipitate? Okay. All right, so now let's look at our first cluster of disorders. Cluster A. Here you have paranoid, you have schizoid, and you have schizotypal. And we'll go through each one individually. For paranoid, suspiciousness and distrustful of others, see hidden meaning in remarks, tendency to see self as blameless, on guard for perceived attacks by others, bear grudges, and not usually psychotic, in touch with reality. So here, what we're looking at are many different characteristics, and this is what I was referring to earlier. We're going to be doing a lot of this. It's going to be impossible for you to memorize all of these character traits, so it might be best to come back to these and try to find a way so that you can identify the differences between them. Maybe cluster some of the characteristics together into one or two things that set that personality disorder apart. Okay. Schizoid, impaired social relationships, inability and lack of desire to form attachments to others, unable to express feelings, generally apathetic, rarely experience strong emotions, and high levels of introversion. And then finally, schizotypal, excessively introverted, peculiar thought patterns, oddities of perception and speech that interfere with communication and social interaction, and highly personalized and superstitious thinking. Okay, so that was our cluster A. Now cluster B, and we have 4 in this cluster: histrionic, narcissistic, antisocial, and borderline. The histrionic, self-dramatization, over-concern with attractiveness, and irritability and temper outbursts if attention-seeking is frustrated. Narcissistic, grandiosity, preoccupation with receiving attention. That grandiosity, again, for that term, you can think of they kind of over-exaggerate their job, over-exaggerate their income, whatever that. It's kind of these grandiose thoughts, or maybe they have grandiose plans for the future. Okay. Self-promoting, lack of empathy, and then hypercritical and retaliatory. For antisocial, persistently disregard and violate others' rights, the inability to follow approved models of behavior, deceitfulness, shameless manipulation of others, and history of conduct problems as a child. And finally, borderline, impulsiveness, inappropriate anger, affective instability, drastic mood shifts, chronic feelings of boredom, and attempts at self-mutilation or suicide. We're probably going to be focusing more on borderline than just about any of the other ones. There's been a little bit more research and stuff on borderline. Okay. And just as I mentioned that, here's a graph that talks about the diathesis stress theory. What that means is that whenever you're dealing with diathesis stress theory, is that there's probably a predisposition to the personality disorder, but then there was a trigger, something that happened in the environment, something that happened emotionally through their family, whatever it might be, that then was kind of a trigger for the disorder to be manifested. Okay. So if you look at the very top there, see genetic and biological vulnerabilities. That's that predisposition. Okay. Maybe the way they're wired genetically. Okay. And so you see impulsivity and you have affective instability. Okay. So those are there. Plus, something happened. Maybe it was trauma. Maybe it was parental psychopathology. Maybe it was loss or rejection. Okay. And these became triggers to then cause the emotional liability that you see, the impulsive acting out, the chaotic interpersonal relationships, and therefore borderline personality disorder. Okay. And then you see how they're all color-coded. So you have the personality traits, the genetic component, and then you have the non-specific psychological environmental risk factors causing the emotions and behavior in blue, and then the labeling of personality disorder. Okay, cluster C. Here we have avoidant, dependent, and obsessive compulsive. Okay. For the avoidant personality disorder, hypersensitivity to rejection or social derogation, self-conscious and self-critical, shyness, insecurity in social interaction, and initiating relationships. Okay, so we've seen a lot of personality disorders that talk about the self-critical, shyness, kind of social isolation, being a loner, that kind of thing. But for this one, it is the predominant character trait, right? Avoidant. What about dependent? Difficulty in separating in relationships, discomfort at being alone, subordination of needs to keep others involved in a relationship, and indecisiveness. Kind of like the opposite of that avoidant personality. These are people that need to be around other people. And then we have OCD. Now, we've talked about obsessive compulsive disorder when we went through our anxiety chapter. Okay? This is obsessive compulsive personality disorder, so it's a lower grade. Excessive concern with order, rules, and trivial details, perfectionism, lack of expressiveness and warmth, and then difficulty in relaxing and having fun. Just remember that this is a lower grade obsessive compulsive disorder. Okay. Now here's some of the specifics I was telling you about with borderline. Treatment, antidepressants, so there again the SSRIs, serotonin selective reuptake inhibitors. These are going to be increasing serotonin. But they also have the dialectical behavior therapy, that's DBT, and this treatment is based on a clear hierarchy of goals, which prioritizes decreasing suicidal and self-injurious behavior and increases coping skills. Okay. Yeah, that's good for that one. Transference focused psychotherapy is also another very specific therapy style for borderline personality. The primary goal here is seen as strengthening the weak egos of these individuals with a particular focus on their primary primitive defense mechanism of splitting, which leads them to black and white all or none thinking, as well as to rapid shifts in their reactions to themselves and to other people. So kind of like a restructuring, a cognitive restructuring, so that they do not split things into black and white. There are gray areas that are acceptable. And then we have mentalization. Okay, and this uses the therapeutic relationship to help patients develop the skills they need to accurately understand their own feelings and emotions, as well as the feelings and emotions of others. Okay, for some of the other personality disorders, we have treatment protocols as well. For schizotypal, we're using antipsychotic and antidepressant medication. For avoidant, we use cognitive behavioral treatment and antidepressant medication. So these are just a couple of the examples of other treatment protocols for some of the other personality disorders. Okay, and then we have psychopathy, formerly called sociopathic personality disorders, or sociopaths. All right. Prevalence is unknown. And antisocial personality disorder, which we already talked about, does have some overlap here. Now, for all of you that watch your CIS shows and all that kind of thing, you probably hear these terms a lot, the sociopaths out there, and it kind of fascinates people watching these different shows and stuff. It is extremely rare. And there's probably, anytime that you're viewing it in a movie or a TV show, it's going to be exaggerated to some extent. But let's learn a little bit more about psychopathy. Okay, there are specific traits at the interpersonal level, affective level, lifestyle level, and antisocial level that characterize psychopathy. For interpersonal, superficial charm, pathological lying, okay, affective, lack of remorse, guilt, empathy, lifestyle, need for stimulation, impulsivity, and then antisocial, poor behavior controls, and criminality. Okay, so you can see these are not good traits to have. That lack of remorse, guilt, that is a key component here, because these individuals will rob or steal from just about anybody. They don't have that remorse, okay, for others' belongings, others' life. We also see inadequate conscious development. We see irresponsible and impulsive behavior, and we see the ability to impress and exploit others. They don't think anything of it, okay, to exploit somebody. Causal factors, okay, there may be a genetic component, or low level of fear, or impaired conditioning of fear. So we could probably go back to that, to certain brain areas that are being activated or not activated enough. The amygdala would be something that we would probably focus on there with the fear response. More general emotional deficits, early parental loss, and then parental loss or rejection. Okay. More for on the developmental side. Remember how I said that antisocial personality disorder can often lead to psychopathology or psychopathy. So here you see risk for antisocial personality disorder, difficulty learning to regulate emotions, high levels of emotional reactivity. Okay, they're aggressive, they're antisocial. If that continues and it gets worse, then they could end up exhibiting fearlessness, low anxiety, poor conscience, and premeditated aggression. Okay? And that's where it's leading to psychopathy. Okay, this is your e-lecture topic item. Please respond to this and put it into your discussion thread for the week. And we will finish up here with a couple more things for the treatment of psychopathy. We're looking at cognitive behavioral treatments, and we're also looking at treatment being very, very difficult for psychopaths. Okay, so if we are successful at all, it looks like it's going to be going through cognitive behavioral therapy. It does offer some promise.